Welcome everybody. Today's very special, not only because it's Friday, the day before weekend, which we all look forward to every week, but we have our very good dear friend and medical director, Dr. Sandeep Gupta, all the way from the land down under. How you doing, Sandeep? Dr. Deep?
I'm doing great, thanks. I'm doing great. I'm really looking forward to today's webinar, Reed.
Yeah, fantastic. This is something that's been a long time in the making. You and I have been dealing with this, putting some slides together and trying to find a way to work mold illness into the FDN protocols. I actually maybe 3 years ago was when we first started talking about having an FDN level 2 and then FDN level 3 would be, I think, the ultimate kind of a CIRS and stealth infection kind of thing. And by the way, folks, I did start just a couple minutes early, so we're not going to actually start the webinar until exactly 4 o'clock my time. And what does that make it over there in your area, Dr. Deep?
It's 10 a.m. Saturday morning here. We are the future.
Oh, you're already into the weekend, all right. So, well, good job. And then also Kendra is on. Kendra's going to manage the back office here for us. Kendra, you have a poll ready to go, right? Do you want to go ahead and launch that so people can start to answer?
Sure. Yeah, I will do that right now.
So what you'll see, folks, oh, I didn't know it showed up on the screen. That's great. This will be the first time that we've done a poll in an FDN webinar. So it's a quick poll. So the question we have for you is, have you dealt with mold illness in your practice? Please select one. Extensively, occasionally, not at all. I'm going to click occasionally. It says organizers and panelists don't vote. Okay, I don't get to vote.
Yeah, you're not allowed to vote, Rick.
Okay, but you guys get to vote. And I think we're getting a whole lot of people already. And then, Kendra, throughout the webinar, we'll just sort of remind them, do you only get to vote once?
Yeah. I think so. Yeah.
So Dr. Deep, we're already at 60, almost 60% say occasionally, and some extensively. I think after this webinar, and you can certainly chime in on this, after this webinar, it might be a lot more, start to understand how pervasive mold illness really is, eh?
Absolutely. I mean, it's just the more you look, the more you find, and it's like that with lots of areas in functional medicine, as you know, Reed, that when you get a new lens and you start looking for things, you see that it is actually much more common than you realized.
Yeah, and like I said, this was something actually first brought to my attention by Dr. Bailey. He thought that this would be a good area for FDNs. I really think that the natural-based wellness coach needs to know about and actually can do a lot of the health coaching involved. Obviously, it might also be an area that really emphasizes the ability to sort of be allied with someone in the medical profession who also knows, some of the deeper ins and outs of it. But what occurred to me over the last few years as we've been looking into this is how many floods and hurricanes and water, and I just can't imagine that, there aren't all of these pockets of populations and communities where it isn't rampant. I mean, I can't imagine it isn't rampant. And, take when we had the Hurricane Katrina, for instance. If I lived in New Orleans, I would certainly want to know, if there's a trend towards, mold-related illness. So after today's webinar, again, I think people are going to have a real good understanding of what to look for. And I'm really excited to share all that.
Yeah, totally. So I mean, flooding is just such a big problem all around the world. We've had, the area I live in, Australia, we've had massive floods over the last 3 years, and that's what, I'm going to talk about that a little bit more today, but that's one of the reasons I got interested in mold illness is I had a house flood, and to see the effects on my partner and myself, it was astonishing.
Yeah, fantastic. So, Dr. Deep, it's past 4 o'clock here now, and I think everybody pretty much, I don't see the numbers moving anymore on the thing, so we're going to let you take over and basically want you to go through all your slides, Dr. Deep. I'll try not to butt in very much at all, and then at the end we'll have some questions for you. And I may have a few of my own, so I'm going to be, if you see me jotting things down here, I'm not playing tic-tac-toe. I'm writing some questions down for you. So let's get rolling, okay?
All right, cool.
All right.
So can you see my screen firstly?
Perfectly.
Excellent. Okay, guys, so I've called this presentation Mold Illness, what every FDN practitioner is seeing and treating but doesn't realize it. And I really mean that, because what we've found more and more is that behind a lot of these conditions and imbalances that we're seeing every day as FDN practitioners, there can be an underlying cause such as mold illness. And in some cases, this is going to be the key that unlocks the door to your client's problems and is really going to get that mileage that you've been looking for as an FDN practitioner. So I really believe that this presentation is super important for taking your FDN practice to the next step.
Perfect.
So, yeah, to get the most out of this webinar, if you don't mind closing any browser tabs and putting your phone on silent, and also having some pen and paper handy to jot down any questions, because we're going to have some question time towards the end. If you stay towards the end, there is a handout that we'll be offering, and also a discount code on our on my course on mold illness made simple, and we'll talk about that towards the end of the session.
I have the handout, Kendra, so we'll make sure that in the follow-up to all attendees and registrants that they get that handout. I'll give you a copy of it right after this event.
Okay, sounds good.
Great. Excellent. Okay, well, I think most of you probably know me, but just a little bit in the way of introduction for those who don't know my background. I basically graduated from medical school in Australia as a conventional medical doctor in 1999. So a good 18 or so years ago. And I actually worked in the hospitals for a good 10 years or so, and particularly in the area of intensive care for 5 years. And that was an amazing little experience, just seeing where conventional medicine actually works really well.
Yeah.
So I'm certainly not against conventional medicine, and if someone's there right on the edge of dying from a severe illness, well, hey, that's where you need conventional medications and conventional care, and it was absolutely great to see that form of medicine working so well. But then what I found in intensive care was then once people had got over their acute illness, whether it be sepsis or trauma or whatever it might be, that's when they actually needed to then build up the foundations of their health. And sometimes that's where the medical paradigm seemed to break down a little bit, is that they never got to build up their foundations of health again, and therefore they continue to suffer with what we call subclinical problems, like a bit of fatigue, some depression, a bit of arthritis, and those were all things that were very treatable through just getting their nutrition and basic other foundations of health right, which is what we deal with in FDN every day. And seeing this and understanding this, and also having a brush with illness myself in 2005, led me to make the switch from serious illness medicine, if you like, over to holistic medicine or functional medicine. And I studied general practice and functional medicine and nutritional medicine at the same time, and became certified as a fellow of the College of General Practitioners and the College of the Nutritional and Environmental Medicine in Australia at the same time, and totally shifted my career over to functional medicine starting in 2010.
Hey, Dr. Deep.
Yep.
I just thought about it. Tell the folks how we met. You know that. You know, it was Bill Wolcott, and then you took the FDN course when it was barely a course. You know, and
yeah,
just a little bit about that.
Yeah, thanks for mentioning that. So as part of my exploration into functional medicine and nutritional environmental medicine, I started looking at some of the courses that were being run out of the United States, and I did a master's in raw food nutrition, actually, finishing in around 2010, and one of the things that the guy running that course talked a little bit about was metabolic typing. He had his own little version of it, but reading his book led me to a guy called Bill Wolcott, and I looked him up and emailed him, and finally got certified in his methods of metabolic typing, which many of you would know is a way of working out individualized dietary needs for people, which is extremely important. Just the concept that there's no one diet for everyone, I thought that's extremely powerful, and an extremely useful place to start with people is just to help them individualize their diet. And as part of this, and particularly, I mean, the forum for metabolic typing, you remember when that was on Yahoo groups?
Yeah,
Yahoo
group, right.
We had, that was just so educational. I mean, we had some amazing people on there. We had Bill, we had you, we had David Vaughan, we had
Dr. Walsh.
Dr. Walsh, he was cool. We had some other really cool people, and I would actually have to say that a lot of my really basic day-to-day understanding of functional medicine came along from that forum. And as part of it, I met Reed and started talking to him more and more about functional medicine in practice, and went ahead and did his FDN course. And that was a whole lot of fun. Kind of got to learn about what some of the testing they were doing in America was through BioHealth Diagnostics and so on. And I started running some of the tests on myself, and then on my clients. And since then we've just continued working together, haven't we, Reed?
Yes, sir. Yeah, that's fantastic. It's been quite a while. Yeah.
Yeah. And I think I mentioned to you one of the, even when I started moving into private practice, I was still having some subclinical health problems, and even though I did all the gut treatment, adrenal treatment, and so on, there was still something that wasn't quite right, and that led me to understand at one point that the water damage building that I'd been exposed to from 2010 to 2012 rather, when I moved up to the Sunshine Coast, and that was a building that had been flooded, that was having an impact on my health. And the only reason I actually found that out is because my wife told me that she was extremely sensitive to mold and water damage buildings, and she knew that it had an effect on her health. If she had not told me that, I do not think I would have worked it out. And that led me to look up Dr. Shoemaker and his protocols, and finally do his physician certification and become the first doc outside the U.S. to become certified in his protocol. That was a wild little ride, and the ride has continued since then. I've just started looking into this more and more into my practice, and see how much of an issue this is with so many different patients.
Fantastic.
So really, so when I first came across this idea that some people may be suffering from mold-related illness, I had no idea of the mechanism or the physiology that might be at play. And Dr. Shoemaker, so I used to have to Skype. Did I tell you, Reed, that I used to have to Skype with him at 1 a.m. in the morning?
Yeah, I'm not surprised, yeah.
Yeah, and he'd be telling me all these jokes and so on, and I'd be running on like
most of them you couldn't repeat here.
Yeah. So I'd be laughing along and on my one brain cell and trying to understand what he was saying with a very very thick Northeast United States accent, but somehow we got through it. And he explained to me that what he had discovered was called chronic inflammatory response syndrome, or CIRS. That's really the technical name. He doesn't particularly like the name mold illness because he thinks it's much more than just mold. And there is a whole bunch of other conditions or other exposures that can cause CIRS, as you know, Reed, like Lyme disease and Babesia, which is like it's like a parasite-like organism which also can be caught from ticks, and ciguatera, and even certain spider bites can cause CIRS. But
certain types of STDs, I think, too.
Right. But in general, in large, mold illness mold rather is the biggest cause for CIRS, and water damage buildings are the biggest cause, and therefore I call it mold illness for short, because people instantly understand what that means. And so really this condition of CIRS was discovered and named by Dr. Richie Shoemaker in the early to mid 2000s. And there's a whole story of how he got into it, which I won't get into today, but it could be an interesting thing to discuss at another time. And it's actually not a fringe, it's not really a fringe area anymore. He's actually co-authored dozens of peer-reviewed papers. And there really is a very extensive library of studies on this condition now, which have been published in the peer-reviewed literature. So it's really quite a well-developed science. And in some ways, the science on CIRS is in fact exceeding the science in many other areas of medicine, because we're actually getting up to what we call transcriptomic medicine, where he's actually looking at the altered expression of various genes in the body. And that's really amazing. That's something that's only started to be looked at with cancer and heart disease and so on, but really hasn't filtered through into conventional medicine in hardly any areas at all. So, I mean, that's totally amazing, the level of science that he's got to. I mean, is that strike you? No.
Let me add something here about Shoemaker real quick, folks. He's not just a pioneer in investigation and treatment of CIRS, and basically he's the mold man, right? He's written the book or books and the papers, things like that. He also has championed the illness as a true illness, sort of up against the those that would say it's not a real illness, and especially I'll just say the insurance companies who don't want to pay for the damage done to the buildings. You know, that's where he's really been taken to task. So when you come up, when you sort of invent something in the the medical field, you're going to have enemies that just don't want to take your word for it. Not only has he done 10,000 cases and all the research, but he's gone up against in court, like gone and fought in court for the rights of people who were sick and were not getting treated right by the responsible parties. So he's kind of, I'll stick up for him any day. No matter what you want to say about Shoemaker, he's stuck his neck out there a lot, and I respect him for that.
Yeah, that's absolutely right. And he's spent really the last 20 years of his life championing this illness, as Reed says, and he's copped a fair bit of flack. There's some websites where people say he's a quack or he's deregistered. That's absolutely not true at all. He's actually very rigorous.
That's what we call fake news.
Yeah, that's right. And at one stage, the Maryland board did review him because insurance companies were starting to get jacked at this condition of CIRS that so many people were suffering with, but there was no reprimand. He ended up, basically just being in good standing with the Maryland Medical Board, and he has retired from medical practice now.
Yep.
So jumping into the actual specifics a little bit more of what exactly is mold illness or CIRS, and what exactly happens. And this is my attempt to make it as simple as possible, that in the majority of cases someone gets exposed to a water damaged building. So a water damaged building is not necessarily one that's really, really obviously moldy. Have you seen the movie Fight Club, by the way, Reed?
Yeah.
Do you remember that building that they lived in that movie?
Yeah, it was obviously a water damaged building.
That was an obviously water damaged building. But a lot of the time a water damaged building is not going to be that obvious. It's going to be one in which there has been some water intrusion at some stage, but maybe the people in the house don't realize it, and maybe there's some slight musty smells or some slight odor, but it may well not be recognized as being an issue. And therefore, I think it's a really important point to realize a water damaged building may be subtle. The second thing is that it generally affects people who are genetically susceptible. And when we're talking about genetic susceptibility, we're not talking about MTHFR here. We're talking about a certain type of genes called HLA. And HLA stands for human leukocyte antigen. And leukocytes, as you know, are white blood cells. And the HLA genes basically have to do with the ability of a person to deal with foreign invaders. So if there are certain genetic susceptibilities, if you like, or certain genetic types, it may mean that a person is not able to deal with the toxins from mold as well as a non-genetically susceptible person may be able to. So for instance, I have a gene type which is called 10552A, which, 14552A it is, which basically is what we call a multi-susceptible gene type. So I'm susceptible to illnesses from mold and also from tick bites like Lyme disease. And did I tell you, Reed, I managed to get a tick bite on New Year's Eve when I was away.
Okay.
Yeah, that's another story for another time. But I have a tendency.
Never mind. Go ahead.
I'll maybe talk about that later if we have time. But if you are genetically susceptible and you get exposed to a tick bite, you have to be really careful and really think about how you're going to prevent getting a prolonged illness such as Lyme disease, because that can really be devastating. So the third thing that then happens, if you take the picture of me being genetically susceptible and being exposed to a building that had been flooded, the third thing that happens is I developed an out-of-control inflammatory response. So why do I develop an out-of-control inflammatory response? Well, the reason is my body is not able to create an effective immune response to the toxins from mold or from the tick bite or whatever it may be. And therefore, instead of getting an effective immune response, I get this chaotic and long-term inflammatory response, which never really works. So instead of getting a good coordinated immune response, which is actually coordinated by what we call the acquired immune system, we just get this chaotic response which is mediated by the innate immune system instead. And basically that immune response becomes the disease. Does that make sense, Reed?
It makes sense to me. It sounds like you're almost describing autoimmune, and I'm sure autoimmune comes in here, but I get that your ineffective immune response creates chaos. We call it metabolic chaos. And what you said was that there's the acquired immune system not working. The only thing is your innate immune response, and it's not able to handle it properly. So you get this, what we would call the stress cascade or metabolic cascade, and I guess in this case just the inflammatory cascade part of that. So of all the possible metabolic chaos cascades, the immune cascade is huge, and that's why I like where you're going here into some of those other parts of the immune system that we're not that familiar with in FDN. We look at IgG and IgE and IgA, but the complementary pathways I think are really critical to understand.
Yeah, that's right. So Dr. Shoemaker basically went and looked at a bunch of markers which are not only not that familiar to FDNs, but even to most doctors. They wouldn't have heard of a lot of the markers that he looked at, because he really went and looked at a lot of the research from ICU medicine on sepsis. And sepsis, as you know, is a condition where people get some kind of, often it's just like a urinary tract infection that then turns into a bloodstream infection, and it basically people's whole body starts shutting down. And what they found is the problem wasn't just due to the bacteria, it was due to the out-of-control inflammatory response that occurred. And they looked at a bunch of complement markers such as C4A and C3A and TGF-beta. And if you go and look in the medical literature, there's thousands upon thousands of papers on these immune markers. But no doctor has ever heard of them, because they're not really part of the most common conditions that they see in medical practice. Well, it's time that we all learnt about them, and because they're very, very important when it comes to CIRS.
Yep.
And here's a couple of the names. So you and I were talking about these yesterday, Reed. So you could say that there's a very delicate balance to the immune system, and there's certain compounds, which we call cytokines, that are anti-inflammatory, or they turn off the fire of inflammation in the body. And then there's certain compounds or cytokines which are pro-inflammatory, or they basically fuel the fire of inflammation in the body. And that's not a bad little concept is to think of inflammation as being a silent fire in the body. And on one side, you've got compounds which are fueling the fire, and on the other side, you've got compounds which are putting out the fire. Well, whether that fire is going to keep burning or not depends on what the balance is between how much you're fueling the fire and how much you're putting out the fire. So in CIRS, there's definitely a big shift towards too much pro-inflammatory cytokines. And that includes MMP9 and TGF-beta1 and C4A. And yeah, these are markers we've been talking about quite a bit over the last few months, Reid, yeah?
Yep. And when you see those elevated, then, pretty much, we don't like to say we're diagnosing anything, but it certainly is pointing the finger at something has ticked off and upset the apple cart. You're pro-inflammatory. And that's good enough for us for right now, because we get that there's anti-inflammatory, and then like the interleukin 10 and 4 and things like that. And then there's the pro-inflammatory, which is not always a bad thing. If you bang your knee, it's going to get inflamed because it's protecting, it's casting it, and it's bringing, other things to bear on this situation that are helpful. So pro-inflammation isn't always a bad thing. Again, there just needs to be balance. We get that.
Yeah, exactly. So, that's a perfect analogy, actually. If you injure part of your body, let's say it's your knee, you want that system to go into pro-inflammation so that you can go and heal that injury in your knee. But the problem is if 6 months later you're still in a pro-inflammatory response and you've still got a super sore knee, well, something's gone wrong. Your body's become stuck in pro-inflammation. And that's where things have gone wrong. So in the same way, if you get exposed to mold, you do want to get a little bit of an inflammatory response there temporarily, but not 10 years down the track. That means that things have shifted permanently towards a pro-inflammatory state, and you haven't got in control of inflammation in your body, and that's become a condition. So does that make sense?
Yep.
Cool. Okay, so jumping right ahead here. What are the symptoms of CIRS? And that's a really common question that people ask. And actually, the most simple answer is anything, pretty much. And the key to realize is that CIRS is a multi-system, multi-symptom illness. And that's the terminology Dr. Shoemaker has come up with. And what that means is that if you've got someone who's just got a complaint, with one system of their body. Let's say they've got the sore knee, as you're talking about, 6 months after they injured it. Well, that's not CIRS.
Right.
If they've just got a bit of bloating and abdominal pain, well, that's just one organ. That's not CIRS. If they've just got some fatigue, again, that's not CIRS. But on the other hand, if they've got fatigue and they've got headaches and they've got memory impairment and they've got difficulty concentrating and they've got a cough, and they've got abdominal pain, and they've got vertigo, and they've got some muscle cramps, okay, well that's probably about 6 or 7 of these boxes here. Mm-hmm. Well, then it's starting to get pretty likely they do have CIRS. So what we're saying is the more widespread people's symptoms are, the more likely it is that they have CIRS. And
by the way, sorry, folks, in the handout that we're going to give you at the end of this thing, this is in there, so you don't have to be scrambling to write all this down. This cluster table by Shoemaker is in our handout coming out to you.
Yeah, and we may also eventually get people a little checklist that they can use with patients, where basically you can do a quick cluster analysis on your patient just as a screening test for CIRS, and that's really useful.
How many clusters out of these 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. There's 13 clusters here, it looks like. How many, if you had all the symptoms in 5, would
No, that's not all the symptoms, any symptom.
Okay, so any symptom of, what, 6 or 8 different ones, or does it have to be one in each box?
Shoemaker found CIRS patients had 8 to 10 symptom clusters in general,
okay,
while normal controls had 5 or less. So that was quite a good differentiating factor. And so anyone who has 6 or more, he feels is worth investigating further to see if they have CIRS. So that's quite a useful thing. If you just get your patients to say, just tell me how many boxes you have any symptom from as a regular thing. I'm not talking about you had sinus congestion just when you had sinusitis last year. We're talking about something, a symptom that you're getting regularly. So we're not talking about diarrhea when you ate too much steak 8 years ago. We're talking about this is a regular thing. So
I need to bring something else up here. And so folks, everybody, this is why we're on with Dr. Deep now, because we're assuming that the person has already been through FDN protocols, because fatigue, as you know, could be anything. And, headaches could be anything, could just be food sensitivities. Sinus congestion, any of these things here, difficulty concentrating, that's that foggy thinking, which is very, very common in someone with hormonal problems, for instance. So the assumption here is that these are persistent after they've been cleaned up around the edges. Now, in other words, CIRS is considered, it could be considered a medical problem. And I've always said to you, look, let's clean up all the mess, get them on a dress program for 3, 6, 9 months, and then if they still have 8 different boxes here like this, well, that's a good time to start looking deeper. But you wouldn't jump to CIR. This is not my initial screening, is what I'm trying to tell you.
Yeah, thank you for that clarification. Yeah, I think that's really, really good just to know where this fits into FDN practice in general. And so if you've done some cleaning around the edges and cleaned up people's guts and hormones and so on, and their diet, and they're getting enough sleep and so on, but they're still having a whole lot of persistent symptoms down the track, well, that's when you might use this cluster analysis and ask the question as to whether the proper investigation for CIRS then needs to take place. And that's really important. So we also need to know where the limits of a functional medicine program are, and where what the right time to go investigating into more of a medical direction is, and that's really, I think, what we're trying to clarify today.
Right.
Okay, I'm gonna jump through that one. That's really not so important, and just talk a little bit about water damaged buildings in general. So this is, what do you reckon, Reed? This is probably an example of a pretty severely water damaged building. I think, yeah. If your ceiling looks like this, please leave your house immediately.
Yeah, listen, a coat of paint is not going to help.
That's right. Yeah, if you're watching this program and your ceiling looks like this, please do not paint it. Leave the building immediately.
Yeah, hide the women and children. Yeah.
That's it. Go directly to Fight Club. Is that it?
Yeah, I wouldn't even let my dog live in a place like that.
You're going to feel pretty bad if you live in a building like that. So what are some of the causes that could lead to this situation? Well, I would say this particular building has been absolutely flooded with water. We're not talking about just a drip of water here in this case. That's absolutely been smothered with water. And what's happened is that you don't just have some mold species growing right inside the building material. They're just absolutely rampant and growing everywhere on the surface, and they're just taken over that whole building. Obviously, this is something we don't very often see in actual life in the Western world, maybe in the third world countries. But often things are a little bit more subtle. And when I was at the conference in Irvine in Los Angeles last year, I told people about how I had ran over my bath at one stage in one of my houses, and the water had basically gone under the carpet in one of the rooms, and I noticed a couple of days later that a little bit of a musty odor had started to develop. So that's a very classic and simple way of understanding how a water damaged building develops. So let's say it's to do with the occupant behavior. For instance, Sandeep is so distracted on his computer that he doesn't turn his bath off, and therefore the water gets in under the carpet, and that starts to intrude into the substance of the building. So what happens is, if you've got water intrusion into the substance of a building for 48 hours or more, you start getting the buildup of microbial growth. So when we're talking about microbial growth, we're not just talking about mold species, but we're also talking about bacteria, parasites even, something called actinomyces, it's actually a microbial soup. There's a whole bunch of things. So we probably have to go away from just thinking of it as being mold. There's a bunch of different species. And what happens is those microbes then start creating compounds which make people sick. And that's not just mycotoxins, that's a whole bunch of other things. There's certain compounds called VOCs, or volatile organic compounds, which are created by bacteria, and that can include substances such as formaldehyde, and they can really make people sick. So that's kind of the progression from the water intrusion, from Sandeep forgetting to turn his bath off, to the water intrusion into the building, to the microbial growth, to the compounds being created that actually make people sick. And it can also be due to building defects, if we're looking in the bottom left corner of the slide. So simple things like, in Australia we have a major problem with roofs where the actual flashing around the roofs is simply not sufficient enough to prevent water from getting into the walls of a building, especially if there's very heavy rains. There can be a whole bunch of other different building defects which can cause problems. Often walls are not sealed properly. There can be problem where even the slab of a building has not totally dried out properly, and that can allow rising damp from the slab of a building to actually go to rise up into the floor, and some dampness to be present in the floor of a building, and that can lead to a certain degree of microbial growth. So there's a whole bunch of different things. Roofs, if they have a little bit of a structural defect, that can allow water to get in. I believe in the United States also crawl spaces are a big issue in terms of mold problems.
Sure.
HVAC can be a big issue. Attics can be an issue. And then we've got natural events such as flooding, storms, hail, snow, etc. All of those things, if severe, that can cause water intrusion to occur into a building. So I guess the main thing to understand is there's a whole bunch of scenarios in which water intrusion can occur to a building, and whichever way it happens, it's going to result in a water damaged building. And some of the ways that we may know that we may be living in a water damaged building is there may be a subtle musty odor. And it may not be bad as that picture suggests, like a lady having to pinch her nose. It may be more that you just notice it subtly when you walk into a room that, hang on, there is a little bit of an odor here when I think about it. There may be just that musty smell. Sometimes you can get an ammonia-like smell or a urine type of smell. That's more to do with bacteria than mold. Well, the musty smell is more related to mold species. So smells are probably much more important than looks, because generally visible mold growth will only occur when you've got a very severely water damaged building. So none of the buildings I've ever lived in have actually had visible mold growth, except the garage of the building that had been flooded did have visible mold growth, but the majority of times I have not seen that.
And after all, I'll just throw this in there, Dr. Deep, the musty odor thing, the damage that it does to us, in other words, the way we ingest these mycotoxins and mold, whatever they are, is inhaling, right? It's the inhaling of them that so smell would probably be one of the first things, since it is an inhaled contributor to metabolic chaos. Yeah, you might just smell it.
Yeah, that's right. And it's very important that people who may be suffering from mold illness make sure that they clear up their nasal passages, because a lot of people have sinusitis or blocked nasal passages, and that's going to get in the way of your #1 sensing tool for finding out if a property is water damaged. So it's very important that they have some treatment for their nasal blockage, whether that be natural or pharmacological or whatever it may be. But I think that's really important. And we'll talk a little bit more about that later on. And then the third thing we've mentioned on the top right of this slide is that if you go ahead and have some professional testing done, or have some testing done with what we call an ERMI or HERTZ-me test. Basically, ERMI or HERTZ-me tests are a type of dust testing. They're not air sampling, because air sampling is a lot more insensitive, or a lot of the time it doesn't pick up a problem. It will sometimes, but not always. While if you go and test the dust with PCR or DNA testing, and the recommended lab is Micrometrics, I believe in New Jersey. that will show up whether there are some mold species there that are causing a problem. And the other option is to actually get some professional testing of your home done. And if you come in and a professional IEP or indoor environmental professional, they may do some testing such as moisture testing. They may run off ERMI testing, and they will also just use their own 5 senses and smell around, look around, have a look behind your furniture. So I remember in one house which I was about to buy, one of the IEPs came in and pulled the bed back, and he said, well, look at this, there's a whole bunch of mold here behind the bed. If it hadn't been for him doing that, I probably wouldn't have realized it. And we found out, and I didn't end up buying that house, luckily. We found out that there had been a washing machine which had leaked while the occupants were away interstate for a whole weekend, and that had actually caused water intrusion into a whole area of the house, which would have been a major remediation job. So, on your own, just walking through a house, you may not realize that there's anything wrong unless you're very, very sensitive. But if you get a professional IEP out to have a really good look, who have a lot of experience, and I will say that not all professionals are as good as each other. There's actually a huge variability. But if you get someone, particularly who's worked with the Shoemaker protocol and with CRS patients, that's really, really important. Such as, there's some particular people in the United States, such as Larry Schwartz and Greg Weatherman and a guy who calls himself the mold guy. They are much more tuned into the subtle signs, and they can find out little things like what I talked about. So moving right ahead, hopefully, does that explain the water damage building concept all right, you think, Reed?
Good. One thing I was surprised about at the mold conference was the number of people in the remediation business who were there. This is not just a medical area. This is an area where people who need help they don't just need, lifestyle and pills, just to treat, this is just not something you just treat, like, oh, you've got mycotoxin, here's your treatment for 2 weeks. It doesn't work that way. It's actually quite complex, and it would include thorough, complete, remediation of the mold problem in the house, and it's not that easy to detect unless you are an expert and use the kind of people. So I was renting a house once, and the refrigerator leaked. The refrigerator had an ice maker in it, and the little tube that feeds water to the fridge came unhooked somehow, and for a week was leaking under, into the car. I didn't realize it. I never walked over in this one area. When I did, I felt wet carpet. I just moved. I'm like, I'm not dealing with this. The landlord wanted to bring in one of those air collectors, and I knew that was a useless test, and forget about it. I literally just moved.
Yeah, and that's a big problem, I think, everywhere in the world at the moment, is that there's a lot of ignorance around water damage to buildings, and real estate agents often will not want to take it seriously, and owners and building corporations often won't want to do the proper remediation that's actually needed to restore the building to a reasonable state. And this is a major problem, and I think that we need almost like a global education program for for real estate agencies and owners and building corporations to understand how much water damaged buildings can affect people's health. Mm-hmm. So moving right ahead, so jumping back to the clinical scenario again, where you've got a client in front of you. Maybe you're seeing them by distance on Skype, or maybe you're seeing them in your office. When should I actually start suspecting CRS, or when should I actually consider mold as a possibility? Let's say this patient's had some parasites, and they've had a bit of adrenal HPA axis dysfunction, we'll call it, and they've had a little bit of estrogen dominance. They made a little bit of improvement, but they're still pretty unwell. Well, one of the big things, and we talked about this already, Reed, is that if you've done a lot of the basics and you've cleaned up their nutrition and their basic hormonal and gut system, and they've still got a whole bunch of symptoms, well, that's going to be a flag in itself. The fact that they've got a multi-system multi-symptom illness that has not responded to the basics. And that's probably, do you think, Reid, that's probably the single most important take-home from this presentation, is that if you've got a patient who's got a whole bunch of symptoms and they're not coming good with your standard FDN management, you've got to think of mold and CRS.
Well, yeah, and it's not that hard to figure out because you can take the history and things like that. So yeah, absolutely. You know, there's I consider this to be critical. That's why we're here.
That's it. And so let's say you've got a client like that. So then at that point you might start asking them about mold. But you've got to realize that just a very basic question such as, do you live in a moldy building? That's not going to identify a whole heap of people who do live in a water damaged building, because that kind of depends on the fact that the client has been able to recognize a building as water damaged, and that's often not the case.
Mm-hmm.
So what we need to do is ask some more subtle questions, like things like, have you ever noticed that there's any odors in your home? Has there ever been a water leak in your home? Have you ever had an appliance leak? Are you aware whether your roof leaks? Are there any areas in your house that you really don't like going into because you don't feel well? Are there any musty or urine type odors anywhere in the house? So you need to ask some very specific questions.
Even a leaky toilet could result in a water damaged building. If it leaked long enough, if you have a toilet that's just running and running and running, and somehow it's leaking down behind the bowl and into the wall and underneath, you know, and then it could go through the floors and be in the ceiling of the room above and in the floor of the, you know what I'm trying to say, that type of thing. And one other area I noticed that's not on any of Shoemaker stuff or here is if you've had a fire and the firemen came, they use a ton of water.
I have never thought about that, Reid. That's a really good point to ask people about.
Yeah, because you know, there are companies that are really good at fire. You know, so once the firemen come, they put out the fire real quick, and then you have a guy come in and patch up the drywall and paint and everything like that. But those firemen leave, you know, I mean, really badly water damaged buildings behind.
Absolutely, and even if you had the sprinklers, for instance, in your ceiling, well, that's going to cause massive water. That's a really good point. I've never actually considered. The other really important one is to ask people: have you previously lived in a moldy building and taken the furniture with you? That's a really common scenario. Is people say, you know, do you live in a moldy building? Oh, no. Well, hang on. Did you previously live in one? Oh, yeah, I did. The one 3 years ago. That was a mess. That was like Fight Club. And so, okay. So, what did you do with your possessions? Did you treat them or anything? No. We just moved them into the new house. It's all good. Well, that means they're in a water damaged building now, because there's going to be contaminants that have been on the furniture. If they were in a severely water damaged building, then their furniture will be contaminated. And if they've moved that into a new building, that's going to contaminate the new building to a certain degree. And I made that mistake myself when I initially was in a water damaged building. I did not realize this problem of cross-contamination. And that's a huge area that we cover in the Mold Illness Made Simple course, how to avoid cross-contaminating a new building. And it's really a really important one. And just understanding what the difference between a porous and a non-porous material is, and which materials can be safely cleaned and which need to be disposed of. That's a really key point. The next one is that if a patient has failed one or more CRS screening tests, and so the main CRS screening tests we use are the cluster analysis, which is that table. I'll jump back to that so you can remember what I'm talking about there. This table is a screening test. So if they're scoring 6 or more, they've got a positive screening test for the cluster analysis. The next one is the visual contrast test, which we'll get to in a moment, which is also called the VCS test, which you can get people to do online. And the third one is basically the history, and just, you know, them having a history of exposure to a water damaged building. They're probably the 3 key things just in screening. And if they've got a positive to one or more of those, that probably makes you want to go on and do more testing for CRS. And then lastly, as I've already said, a lack of response to the standard FDN protocols is also quite an important differentiating factor for you to start thinking that there's an inflammatory process here which is driving this patient's illness. Anything you want to add to that, Reid, at all?
Fantastic. Yeah. Just when it comes to the CIRS screening, there's, I would say, initial screening, and you could screen a little deeper. You can work it along, because if you try to do everybody like a huge comprehensive CIRS assessment based on all the Shoemaker stuff, it's very complex and very expensive, and the blood work isn't that easy to get. And so what we're trying to do now, folks, is make it easy. Like, we have, I don't know, maybe 45 or 50 people now in basically research and development. If you've talked to me and you've done the VCS test, which is online, and I probably did a nasal swab with you, and then so we got you doing some things just to see how you do. Because again, I can't diagnose CIRS. I don't really want to sort of play that game, and now you're a medical case, and there's all kinds of potential complications with that. We're trying to see where the boundary is between us as FDNs being able to deal with this and really needing to refer to a CIRS specialist. And one of the main reasons for that is there aren't enough. I mean, Shoemaker has only certified 15 or 20 people in the country, and one out of the country, and you're looking at him right there, Dr. Deep. So, so there aren't enough physicians to refer to even. So what we're trying to do is see where those boundaries are between what we can do as FDNs and what might actually need like a prescription. So some of the treatments to bind up some of these mold toxins are tricky. And if you can't bind up and eliminate the mold toxins, you can't get better. And it has to be done in a certain order and things like that. So what we're doing is actually just R&D. We're doing research and development. And then, so now we're at the point now in that where we've run a bunch of VCS tests and a bunch of nasal swabs, and a few people have actually done some of the blood work for the inflammatory markers that we looked at earlier. And now we want to get more people in the system. So that's why we're offering this course to make you more aware, make you able to do the initial screenings and see who might want to enter the world of just how FDNs are going to be able to handle this. So we're creating, instead of taking another year and coming up with some big program, we're going to just let everyone help us develop it. It's just it's a grassroots movement, if you will. Because health coaches are going to have to be able to recognize this and deal with it, and there's no one better prepared than FDN health coaches.
Absolutely. I think this is just a really great area that we can assist the Shoemaker certified physicians in being able to identify people who have this illness or who likely have this illness and package them up, give them some basic understanding of the illness, and then they can work with the FDNs perhaps and a certified physician. And it's really all about working hand in hand and doing what we can to help the patient. So I think it's a really great area in which FDNs can be involved. And so just going back into screening a little bit more, kind of these are some other things. Is the patient currently or at any time since getting ill been living or working in a water damaged building? So that's kind of a very simple question, but as I said, you need to get a bit more specific than just saying, do you live in a moldy building? Now this is a very subtle one. Do you notice symptoms worsening in certain buildings or places? So an example with, like, my father has a problem with essential tremor. It's almost getting a little bit more towards Parkinson's. And I went and stayed with him a few months ago, and his building's definitely water damaged. But sometimes you have a client who's not that willing to look at it. He wasn't too interested in knowing about the fact that his building was water damaged. But when he came up to stay with me recently, the interesting thing I noticed was we went and got a holiday house and it was water damaged. But as soon as he went in there, he started coughing and he started looking for us. Then all of a sudden, on all of a sudden it went ding on my register. Okay, well hang on, it's not just that he's living in a water damaged building, but now I've got some evidence of causality. I can see that his symptoms are actually triggered by a water damaged building. So that actually gives a lot more credence to the idea that mold is causing some problems if the patient actually notices things when they go into certain buildings that are moldy. So I hope that makes sense. But that actually and one thing you can do is get patients to, if they're really not sure, is go camping for 3-4 days. Nothing wrong with getting out camping, especially if you live in San Diego, right? And then come home and see what you notice. And people are just going to learn to tune into their senses a bit more. And all of a sudden, quite often, people start noticing things about their symptoms and their house that they've never noticed before. It's kind of like when patients go off gluten and then they have gluten, all of a sudden it's like, ding, okay, I see there's some causality here. But if they were eating it the whole time, it's almost like that their switch was always turned on, so therefore you don't notice when you then have an exposure. But if you then go and turn that switch off by going out and going camping for a weekend and then going back into your house, and then you notice, hey, my brain fog's just come back, my fatigue's just come back. Well, hello, there you go. That's very important information that you've just gained there, because you've gone and turned your inflammatory pathway down a little bit. You've turned the volume down, and if the volume all of a sudden goes up again when you go back into that building, well, that gives you some evidence that there's some causality. So that's actually a really important point. We cover that a lot more in the course. But, again, you can ask people if symptoms improve on holidays, but a lot of the time that's not a very useful question, because people go and stay in water-damaged buildings the majority of the time. So they probably are not going to notice things, or it's really only if they go, camping, and you've got to make sure that people's tents aren't moldy as well. But generally camping is going to be pretty safe. And then, as we said, do they have symptoms in 6+ categories of the cluster table? That's something that we can easily do on all of our clients. And then the VCS testing. So the reason that the visual contrast test has got to do with the ability for people to discern fine differences in contrast. So if you look at the diagram on the right side of this sheet, well, most of you can see the lines on the left-hand side column, I'm sure. But when you start going up to the 5th column, it probably gets pretty darn hard to see those lines. So this is where it gets into the subtleties of people's ability to discern fine differences in shades of grey. And the key to understand is, because of these inflammatory cytokines, they actually affect the nerve to the eye, the optic nerve, and it causes an inability to be able to discern changes in visual contrast. Or to be able to discern fine shades of grey. So if you see the example in the middle of this slide, this patient has got a whole bunch of crosses where there should be ticks. So to pass, you need to have above a score of 6 in the D row and a score of 7 or above in the C row. But this patient's nowhere near that, and therefore they've failed the test. So you can get them to go and do this test online at www.survivingmold.com, and they do have to pay for it. It's about $20 each. One option is, as a practitioner, you can buy a bunch of screening tests in bulk and then charge your patients $10 for it or something like that.
Not charge them, just to screen them. Yeah, if they're already your clients, it makes a great gift. Let me throw one other thing in there, just so people understand. This is an amazing discovery that cytokines and other things affect optical nerve, causing changes in visual contrast. That is a faculty of vision, and I describe it to people like this, Dr. Deep. If we can all see a black cat on a white shag carpet, we can all see that because there's, we have this faculty of vision called, contrast. But can you see a white cat on a white shag carpet that's, where they're very similar in color? So if you had poor or defective visual contrast sensitivity, if that faculty of vision is affected by some toxin in your body, then that's what visual contrast is. You wouldn't be able to distinguish that. And it doesn't mean you can't read black letters on white paper, so you probably don't know you have a visual contrast sensitivity issue.
Yeah, that's right. So it's just it's a very simple test really, and as Reid says, you can give it as a little gift for your patients. You basically give them your username and password. If you've gone and created an account, they are able to then download the result as a PDF and email it to you. And what you can see in the center of this slide is part of the result. And then you can then tell them, well, okay, you've passed the screening test, or you failed it. And so if you failed it, well, maybe we do need to look further into this mold illness. And the accuracy is pretty good. There's probably only a 2.5% false positive rate. So if it comes back as fail, it means something. Unless they've got a major eye problem. You've got to make sure they don't have a major eye problem. And false negatives are only a 7.5%. So people who have particularly good vision, like photographers or artists, they sometimes can pass the test even if they have the illness. So that's worth, just because they've developed their eyesight so well. So it's worth keeping in mind. And particularly young girls, I find, will tend to sometimes pass the test even though they have the illness. So just keep in mind that if they pass the test, that doesn't totally exclude the possibility that they have CIRS, but it's still quite a useful screening test. This gets a little bit more complicated, but another screening test you can do for CIRS is to check their HLA gene types. And it's most recommended to do that test through LabCorp, and we're going to have that test available through the Medical Director program hopefully before too long. And so what you get back is a number for each of these different genes, like the DRB1, the DQB1, and the DRB3, 4, or 5. And then there's a certain protocol, and Reid and I will be able to help you with this, but there's a certain protocol where you can match it up to Dr. Shoemaker's table or Rosetta Stone, where he's written down all of the gene types which appear to be susceptible to CIRS. So as you can see, the top line of his table lists 4353 as a multi-susceptible gene type. So 4353 is actually a gene type which only about 1% of the population have. They're particularly susceptible to type 1 diabetes and rheumatoid arthritis, and they're patients who are very susceptible to getting mold-related illness. So if your patient has that gene type, that gives a lot more credence to the idea that they may be suffering from CIRS. So, stay tuned for more information on this as we go on, and we're going to have to keep providing education as we go, but this is something we should be able to offer through our Medical Director program.
Yes, sir.
Okay. And further, these are other tests that we will be offering under the FDN Medical Director program. This is more when you're actually already done the screening, and let's say someone's positive for the screening test and they really want to go ahead and let's say they've been doing FDN for several years and they really want to get into this whole idea of CIRS and find out if this is what's affecting them. So on the right side of the screen, there are certain compounds that are going to be increased. These are compounds that are fueling the fire of inflammation in the body. And that includes TGF, beta-1, C4A, leptin, and MMP9. And most of these are done with Quest laboratories, except for MMP9 is generally done with LabCorp. And then on the left side of the diagram, there's different hormones which can be increased or decreased. So estrogen levels are generally increased, and you can do that with any LabCorp or Quest. I know a lot of you would probably be using the Dutch test at the moment for looking at sex hormones like estradiol, and that's perfectly fine too. And then looking at things like testosterone, DHEA, VIP, and MSH. So you guys are probably dealing with testosterone and estradiol and DHEA imbalances every day. But if you get someone who's not responding and just won't get out of this estrogen dominance pattern, that may be another little tip towards the idea that they could have an underlying inflammatory problem. Same thing with ACTH cortisol issues. If you find that you've been treating their cortisol for years and it's just not coming good, that could be a tip-off that they've got an uncontrolled inflammatory process going on. VIP and MSH, they're generally done with Quest and LabCorp respectively. If they're low, what that means is you've got a low regulation of the inflammatory pathway in that person's body, and therefore, you know, VIP therapy is highly likely to be beneficial for them, and we'll talk a bit more about that. Okay, so what can we do for these people? Anything? Let's say I've had a client who's gone ahead and done some of this testing, and they have a high C4A, they have a high TGF-beta1, they've got a low MSH. We're pretty much thinking that they've got the real deal here. They've got CRS. Well, can we start educating them about what they need to do? Mm-hmm. Absolutely. Absolutely you can. And so we start at the bottom of this pyramid and work up. And as Reed said, you know, a lot of the time you're going to be probably wanting to work with a certified shoemaker physician, but these guys are very, very busy a lot of the time, and you can help support them along the whole way by educating the client and helping provide support and lifestyle advice. And one of the first things people are going to have to do is get away from or remediate their building, and that's hugely important. And there's a whole bunch of education that needs to happen around that. So, for instance, Reed, you had a recent client that we had been sharing we've been sharing information on, and I think that information about them doing a Hermy test and realizing that they had severe water damage to their home, that had been pretty important information for them, hadn't it, really?
Oh yeah, it's critical. And this is someone who'd done all the FDN stuff, was much improved, you know, getting herself in shape, and yet had and fatigue, one of those clusters, and a couple others were in there. And we just said, let's look at the VCS, and then, you know, we did the Marcons, which is in the blue there at the bottom, and found some antibiotic-resistant coag-negative staph, and then her house got tested, you know, and sure enough, both her house and her garage, where she had just remodeled into an office, had maybe some old water damage, but anyway, they found mold. The Hermy test showed mold, and it was the kind of mold that you don't want. So there's a score. That's where the hurts me comes in. The score was enough to say, look, you're never going to get better if you don't remediate.
Yeah, absolutely.
And, you know, so the rest of the protocols, the binders and things, the Marcons treatment, that's where we're playing around with things, because Shoemaker is a strict medical doctor. Like, he only will write a prescription, and if you haven't run, you know, 1,000 of the, you know, you need to have thousands of cases before he'll even consider anything botanical, and even then he may never, you know. So not like I'm just trying to jump through his hoops, but what I'm saying is that we've been sort of playing around with, you know, can we do some alternative things that aren't so hard to get as those prescription drugs. And then the hormone, same thing with hormone immune correction, VIP, but you haven't got there yet, so yeah.
Yeah. So as you say, as Reed said, so in that case that he was looking at, that patient had a lot of mold growth in their building and in their office, and so the critical thing for that person was to work out, were they going to be able to remediate their house, or did they need to just move? Moving seems like an easy option, but the problem is you may not be able to find another house that's not water damaged. So in any case, once you've done that, if you've remediated your building satisfactorily, you're in a really good place to recover then, and because basically you're not getting in more microbial compounds from your home. And then you can go on binders. So the most common binder that is used is cholestyramine, which is also called Questran. There's another one called Welcol, which is used.
Yeah, that's
a good one too. The classic treatment for Marcons is called Beg nasal spray. Then there's a bunch of other steps which I won't get into today, but the final cherry on the top of the pie, which Dr. Shoemaker is very excited about, is VIP nasal spray, which is really a form of bioidentical hormone therapy, because VIP is a hormone in the body, and often it's continued for 6 to 12 months, and it really brings people's inflammatory cascade right down, brings their levels of C4A and TGF-beta right down, and it brings their VIP and MSH levels up. So it's really, really, really exciting, actually. And the recent research from Dr. Shoemaker is that it also expands area of the brain which have been shrunken due to this illness, which does happen. Okay, Reed, so I've got a case. How are you feeling about time, though? Do you want me to do the case?
It's Friday evening for me, 5 o'clock. I'm fine. I'm not busy till later tonight, so I'm totally good. I think we should do it. Well, anyone that needs to go can go and come back. Everyone's going to get the recording, but what you want to do is stick around, because in just a few minutes here we get through this case, and Dr. Deep has a very special offer for everyone, which I want everyone to hear.
Okay, great. Yeah, thanks. Yeah, I really appreciate people hanging around, especially if you're on the East Coast there. It's probably getting into social time on your Friday night, but I really appreciate if you can give me about 10 minutes for this case, because it really it gives a good example of how this might, how a case of mold or CRS might actually present in your FDN practice. So this is a patient who was here in Australia. They a 29-year-old female. They were born in Northeast United States, somewhere around New York or something, and she didn't move to Australia till late teens. But basically, the first thing that was quite clear is that she had had a lot of social and anxiety issues as a young girl, and had a difficult family life as a child, and had spent a lot of time seeing psychologists and so on. So there's sort of a history of trauma there, which I think is also a very important thing to note. And sometime during high school, she started getting a lot of gut symptoms, such as abdominal cramps, gas, bloating, and diarrhea. So again, so far this is all sounding pretty much like just two organ systems. So we've got the brain and we've got the gut at this point. It's sounding pretty much bread and butter FDN. Throughout college, she had ongoing GI problems. Sometimes she would have debilitating abdominal cramps, about once a month, that would last throughout the night, and often she wasn't able to keep going with her study, and she had to take days off, and sometimes it interrupted her ability to do exams and so on. So it was really getting in the way of her life. She saw a specialist gastroenterologist at the end of her college time, and she had multiple stool samples done with BioHealth and other labs. Oh, sorry, no, this was prior to the BioHealth stuff, sorry. This was stool samples with the more conventional labs, which were all normal, and her colonoscopy was also normal. So she had been screened from a conventional medical point of view, and she was all good. About a year after this, she was diagnosed with anorexia, and this was by the conventional medicos again, and she was referred to a nutritionist, to put some weight back on and maintain healthy self-image. So she was kind of going down this whole medical platform. But then she started seeing more and more practitioners, and she moved to Australia when she was around 23, 24. And around that time, she started developing a bunch of other symptoms, such as fatigue, anxiety, dizziness, night sweats, and insomnia. So it's starting to sound a little bit more multi-system here. Mm-hmm. Rather than just brain and gut. We're starting to get some systemic things like fatigue, dizziness, night sweats. I believe she also started developing some memory and concentration problems. Mm-hmm. And so you could say she's getting close to having what's described as a multi-system, multi-symptom illness here. And she consulted an FDN practitioner in Melbourne who did some basic work on her, and then referred her on to me for integrative MD input, because she was thought to be a bit of a hard case.
Good one.
Yeah, and originally her testing showed, so a metabolic typing test showed she was a fast oxidizer. So she went on to a serious carnivore sort of diet, and that did seem to help settle down her blood sugars, and which helped her anxiety. So a certain degree of her symptoms were probably just due to the fact that she was on the wrong diet, and we know that. We know that's really important for anyone. She showed some gut testing, showed an unidentified parasite, and treating that seemed to help a little bit. She had a bunch of things on her hair analysis, like a low sodium-potassium ratio, which is just an indicator of her having a lot of blocking factors, according to Bill Wolcott, and just having been unwell for a long time. And so she was put on a foundational nutritional support program addressing these imbalances and focusing on rebuilding the mucosal barrier. And this is all pretty standard FDN. You guys dealing with this every day. This was her MT or MRT test rather. So she had some food allergies going on. We got her to eliminate anything, particularly these fruits on the right that she was allergic to. But I think with the fast oxidizer diet, you basically don't have any fruit anyway, as far as I recall, hardly any.
Not much.
And this was her bioscreen 401H. She showed a little bit of E. coli, but it was pretty clear. It was really clear. Yeah, and her this was her metametrics testing, which I think is now, Genova and metametrics are one. But she showed this parasite that was present, and the taxonomy was unavailable, so gave her some antiparasitic agents for that. This was her hair analysis. As I said, she had a very low sodium-potassium ratio. There's something called a bowl pattern, which is described by Dr. Lawrence Wilson as being a bit of a yin-deficient state, where a person may be feeling trapped or stuck in a certain life situation. I actually find that interestingly, those little descriptions are very accurate, actually. It's really fascinating.
This is the ARL test. A lot of FDNs might be using the trace minerals lab. I like this one because we find the aluminum a lot more often. It's not on this page, but the other thing is that when you see everything trending low, just nothing is high on this test, and I always think of digestive problems, like they're not even breaking down and absorbing their nutrients, and things like that. Sometimes, just sort of a screening for very poor digestion.
Yeah, that's a great point. And just this whole issue of just realizing this person is very depleted. Maybe they're feeling very stuck. They've got a degree of manganese toxicity and copper toxicity highly likely, even though the copper and manganese are in those ideal ranges. Usually where you see them coming up like that, usually once you've done a bit of work on them, you'll generally see that their copper and manganese will then come up, and they'll excrete a bunch of toxic copper and manganese and iron. And so this is a person who's got a fair bit of depletion and toxicity. So that's a whole other thing to go into that more, but just that gave us a bit of an idea. And we continue doing thorough coaching around the DRESS approach to health, made sure she was getting enough sleep and exercise and so on. But she really stuck to it pretty well. But she did get some improvement, but it wasn't as much as she was looking for. She became a little bit more disillusioned, and probably each of you have had an example of a consult where someone turns up and says, look, doc, you've been doing really, really well for me, but look, I really just need to get some improvement here. I need to move on with my life, and that's kind of where this came to. And then sometimes the client just really is asking for you to think a little differently all of a sudden. So she'd been doing this for a few years, and after discussing it with her thoroughly and understanding what her needs were, we decided to explore mold as a possibility. And so it's really very much up to your clients, and just discussing with them which direction they want to go into. So maybe, you may have some cases in which someone hasn't improved as much as they wanted to, but they really understood that they needed to go back and look at their emotional issues again. Well, then you can go in that direction. But in this case, through consultation with the client, we decided we wanted to look at mold. And it's great to have that tool in your toolkit to be able to do that. And so this is one of the screening tests. This is the VCS done through surviving mold, and she did fail it, even though only just by the D row in the left eye being a fail. But it was a fail. And then actually survivingmold.com does do a cluster analysis already. And these are the different symptoms that they ask people to fill out, and it marks this as a positive cluster analysis for symptoms. So already she's failed the two of the three screening tests, and we ran a nasal swab on her. This was the old layout that used to come from Microbiology DX, and she was positive. She was positive for Marcons as well. So that's another little thing you sometimes can do. And so then we decided to go. She was going back to the United States to visit her family, so I gave her a request form for Quest and said, well, while you're over there in the United States, why don't you just run some diagnostic tests for CIRS? And lo and behold, her TGF-beta was more than double the upper end of the reference range. So normal is, triple really, isn't it? Yeah, so normal is up to about 2,380, but she was 6,180. And then the VIP levels, the normal levels are 23 to 63. Well, hers is 24. Well, that's pretty darn close to the lower end of the reference range. So I considered that to be an abnormal. And then her arginine vasopressin, which is also known as antidiuretic hormone, that was less than 1. So that was abnormal too. So really she's got 3 abnormal biomarkers there, which is a really key part of making the diagnosis of CIRS. Interestingly, her C4A level was actually normal. And you will sometimes see this, that patients have one biomarker which is normal, but don't let that put you off the diagnosis. So, I mean, as a medico, I was able to diagnose her with CIRS. I also had a neuroquant test done which showed shrinkage of the caudate and area of the brain and swelling of the forebrain parenchyma and cortical grey matter and pallidum, which is all the classic signs of mold illness as per Dr. Shoemaker. But that's not something you need to do, but just because I have access to that, I decided to run it. It can give a little bit of additional information. And so what did we do? Well, we found out that she did have some mold growth in her house, and so we did some remediation of her house, followed by cholestyramine and BEG nasal spray. And this is all just very standard treatment for CIRS. And then we added in some other steps, and finally leading up to VIP nasal spray. And slowly, it wasn't super dramatic, but she made a gradual recovery with regard to her energy levels, anxiety, and other symptoms. And basically she's at a stage now where she just comes every 6 months and she's smiling and she's like, what are we going to do next, doc? And she's pretty much happy with herself. She just sometimes goes off her diet a little bit and then starts feeling a little bit crap for a little while, but basically she's pretty good. So that's probably an example of where exploring CIRS has given a really good result in this case. And I was able to basically guide that patient through it. If you were just an FDN, you might have needed to work with an MD as well. But the client would have been really happy that you had found this disorder that not many people know about. And
exactly.
Work through it. Yeah.
Exactly. We're in the trenches, folks. We're the troops. You know, we're meeting people where they live and work, and they have actually been turned away by physicians because physicians aren't trained in this. So, you know, they walk in with headaches and whatever, and, you know, the doctor might do their normal blood work and nothing shows up, right, Sandeep? Now, wouldn't there, a standard CBC chem panel is not going to show any of this stuff.
No. And even the ESR and CRP, which most doctors run as inflammatory blood tests, they're not going to show anything up in CIRS. That's
yeah. There might be a couple other predictive biomarkers that would show, but there's not enough of them to say, oh, CIRS. They'll never make that diagnosis. Yeah. So again, we're the troops. We're in the streets and houses, you know, with people, and we can screen out for this stuff and get those people the help they need. That's the trick. That's what we're in business to do. And now, again, I think everyone needs to do the DRESS program and see what shakes out. And when it's persistent, in other words, you're getting limited results with therapeutic results with some of the stuff we do and tricks we might play, you know, then this is a good way to go. And we're going to be able to get lots of more people into our R&D, and eventually this will be something that FDNs do as standard. This will be standard. Yeah, we'll have our arms around this. You know, it's just as soon as we can get a handle on more of the testing, you know, work that into the MDP, and then more of, you know, maybe leaning towards, you know, trying some, people are willing to try some natural therapies, you know.
Yeah.
I mean, it's not going to match what cholestyramine or Wolcott can do. I took Wolcott myself, and then the BEG nasal spray, you know, I tried an alternative to that, and you know, BEG just works better, you know, because it's a prescription, it's stronger. But, you know, we've been playing around with different nasal sprays and things like that. So we're going to have our arms around this even better than we do now. But you know, we're going to be on the cutting edge, that's for sure.
Cool, man. So it's pretty exciting. So really, I guess one of the take-homes after this for many of you is that, you know, you're probably realizing that diagnosis and treatment, so the screening part's not that difficult, but the actual diagnosis and treatment can be pretty confusing and complicated. These are some of the different words you're going to come across, like the hippocampus and stachybotrys and amygdala and hematomium, and you really want to know what you're talking about, because clients know pretty quickly these days when someone really knows what they're talking about or is just winging it a little bit. And I really developed this 8-week online course initially for clients because there were so many clients who felt overwhelmed by the information, and particularly the information that's on the internet, because it was so confusing. There was contradictory information, and the information on survivingmold.com is extremely technical, and there was definitely a need for people to be, and the other thing to realize is clients are also, their brains are actually inflamed, so their ability to actually pick up information is not that great. So this course, it's been endorsed by Dr. Shoemaker. He really likes it. But the key about it is it's very step by step, and we don't try and teach the whole thing all at once. We take people through certain areas one at a time, and I've realized that this is actually a really useful course for practitioners as well, because it gets you to the stage where you get the basic concepts, and so you can find out how to screen and diagnose CRS patients in your practice. And probably screening is going to be the biggest thing. You guys, and then you can decide what you want to do. If someone shows positive on the screening, maybe you might decide you just want to send them to a physician, or maybe you decide you want to also be involved in that process. It's all up to you, but this course can help you to work out the process. We then delve into each biomarker, such as C4A and TGF-beta, so you can give people an intelligent answer to what does it mean that I've got a high TGF-beta. And that I've got a low C4A. What does that exactly mean? You can learn a bit about other sources. So we haven't talked about this too much today, but other things like tick bites and Lyme disease, Babesia, ciguatera, algae, how do those fit into it, and could they be an issue for people? We definitely cover that throughout the course. We cover the whole CRS treatment protocol, or the Shoemaker protocol, in depth. What are the different steps? What are the medications? What are some of the tips and tactics, especially for people who are having problem? Let's say someone's having problem with cholestyramine. What can you do? Maybe you can give them some magnesium to help with their gut a little bit, and some other little simple tips like that you can help people to actually tolerate the medications a little bit better, or giving them some xylitol nasal spray so they can tolerate the beg spray a bit better. And then next, where to send patients. So we will cover the Shoemaker certified practitioners. And I think, Reid, you wanted to make a comment here?
Well, just that I think everyone should take the Mold Illness Made Simple course so that you can get up to speed with where we're at. This basically is our understanding of it. Sandeep is our medical director and our liaison to this. By the way, our other medical director and advisor, Dr. Tom Palucki, is also being certified by Shoemaker, and so I think, and he might be the only chiropractor on the planet that Shoemaker would do it. So as the FDN clinical advisor, slash other medical director, we're getting, this is a critical area. I see this as the future, and part of the future for FDNs. We need to have our arms around this as much as anything else I've ever seen. I'm not as tickled with some of the other big areas that people seem to be infatuated with. It's like what about this test and what about that test? No, this is a huge demographic of people that really need our help. So we've got to be prepared. If we want to be the health coaches of now and the future, I think we already are top of the heap in terms of what type of health coaching is available, but we're going to stay there, and so this is what I have decided FDN needs to do, and we just are incredibly fortunate to have Dr. Deep as a medical director and Dr. Tom, and so that we can do that. So you're seeing right now, this is the extent of our ability to deal with it. So we're laying it out there for you, so that maybe you don't go cockeyed off in some other direction. We're going to try to offer it to you the way we think is best.
Yeah.
And there's going to be more. This is sort of step one, if you will.
Yeah. Yeah, that's right. And the time commitments are probably around 2 to 3 hours per week for 8 weeks. So, look, if you work until 10 p.m. at night and you've basically hardly got a spare second in your week, maybe this isn't for you. we need to have a couple of hours you can put aside on the weekend and really give it some time to get it. And because these are major concepts, but we're not saying it's 50 hours a week. It's two. If you really concentrate and give it 2-3 solid hours a week, you'll get through that week, and you should be able to answer the quiz at that end of that week and pass it successfully and get through to the next week. So it's not a massive time commitment, but you need to be able to give it a chunk every week to get through it and to advance your knowledge on CRRS. So some other areas, sorry, I forgot to mention also, we do cover mold avoidance. So those patients who are like super sensitive, some of you may have experienced these patients, some of them may want to explore extreme mold avoidance techniques, and we also cover that to a certain degree. We also talk about building testing and remediation. So some of the testing to know whether a building is a water damaged building or not, and we cover ERMI versus HERTS-me testing versus air testing. A little bit about the basics of building remediation. So for instance, using HEPA vacuum cleaners and HEPA filters and damp wiping and all those other kind of do-it-yourself remediation techniques. And then discovering which possessions can be remediated and which cannot. That's actually extremely important. And then, some of the differences between the common air filters and air purifiers out there, because that's going to be a really common question you get asked is, should I just go ahead and buy an air filter? Well, hang on, it's not quite that simple. You have to think about what the type of air filter is, what the situation is, what you're trying to achieve. So this is all technical information. And basically what you get is 18 video lectures and the slides that go along with them. And so on the left-hand side there, this is basically the format of the PowerPoint. So you can see that one of the PowerPoints about cytokines just explains what a cytokine is. So they're chemical messengers or proteins used by immune cells to communicate with each other. So the videos are all basically of my voice talking along with the lectures. There's a private Facebook group once you hit week 5 where you can ask questions. There are webinar archives. So we're doing a monthly webinar, and there have been about 5 so far, and those webinar archives are actually very interesting. And so I really recommend watching those once you get access to the course. There are weekly quizzes to make sure that you've understood the basic gist of the chapter, and then there's a high-quality PDF workbook for each chapter. So there's quite a bit of material there. And so for you guys, we've set up a coupon code for the next 48 hours, and it's FDN Clarity. So there's a 25% off discount. It's usually $199. We're running it for $149.25. Because I really want you guys to learn this, and I really think it's going to make a huge difference to your practices and to your clients. I really think it's great that FDN practitioners should be able to recognize this illness and at least be able to do some screening and pass people on to a physician when needed, or go ahead and do some further testing under the medical director program. And that's what you guys are going to be able to do at the end point of this, and I think that's going to significantly enhance your practice. So if you want to join up, we'd be delighted. If you don't have enough time right now, well, find some time and then join up. But I think you'll be very satisfied with it.
Yeah, jump in, folks. We're going to follow up. There will be a lot of follow-up. Now, what I'm noticing is that just about everybody who signed on in the beginning is still on. So thank you for your patience and dedication to this material. We'll send you out what you need, the follow-up and everything like that, because a lot of people sign up for webinars and they aren't actually able to attend. They're depending on getting a repeat, replay and that sort of a thing. So Kendra is on with us. And that should wrap it up. And if you are using the coupon FDN Clarity, of course, you're going to save money. I think you're giving it away at $200, Dr. Deep. I really think we are. And even with the discount, even better for everybody. So thank you a million for that. There's just a couple questions. I've been answering some questions in writing here that are fairly simple. There's a few others that are actually in the guidebook that we're going to send out, because you're going to get a recap of all this in a guidebook. Everybody will get that. You'll be able to flip through the pages real quick, and it's got live links. You can click here and there. There's questions about the protocols. I think it's a little complicated to get into that right now.
So this is the one with the posterior cortical atrophy?
Yeah.
Okay.
Oh, you can see the questions too. Good, good.
I can see the question too. Do you want me to quickly read that one and give a very simple answer?
Yes, please.
So one person's asked the question, great info, thank you. Working with a 51-year-old female diagnosed with posterior cortical atrophy, an atypical form of Alzheimer's. Typically toxic, turns out to be Marcon's positive. Results from testing house are positive. Working with a functional MD now. Looking forward to the course. So, yeah, look, I think the course will give you a lot more info for how to deal with a patient like that. And there's a guy called Dale Bredesen who's in Los Angeles, and he's found a lot of Alzheimer's patients do have many of the features of CIRS, even though they may not meet the case definition. And just doing some of the basic treatments with them, such as the cholestyramine and the VIP nasal spray, will often help them very much. So very glad that you're dealing with Alzheimer's patients, because that's a very, very hard area. And yeah, if you can help people with Alzheimer's, I mean, it's worth, it's worth all the tea in China, because these people, if someone at 51 is losing their brain to Alzheimer's, I mean, that's just devastating.
Yeah, and it's not fair. We could do so much good for people when we get better understandings of some of these very big topics. This is not just like some of the other sort of advanced materials and different things we've done for people, for FDN world, how to run a certain lab, this is not like that. This is huge. This is a whole program that we're going to get our arms around, but it's going to take time. Molly wants to know, how's your personal mold illness doing?
I'm recovered. Yeah.
Yeah, see, if you move and you treat yourself right, you can recover from it. So that's the good news, folks. There's some other questions about the genes and things. Molly, I'm just going to send you the guide. Most of it's in there, and I know you're going to take this course, so you'll get it all rather than try to answer that now. The inflammatory markers, they're all there, and that sort of a thing. So, Sandeep, we're going to let you go. And I'm going to go too. It is getting late on the East Coast especially, and just really, really, really appreciate everything that you're able to offer and do for us. You're a great guy, Sandeep, no matter what they say about you.
Yeah, I know. Yeah.
We should do one more poll. Who's better looking? No, I'm kidding. We should actually do a poll on, is Dr. Deep better looking with his hair or in his professional shot with that real short hair and glasses? I don't know. Yeah, I go for the hippie look myself, so I think you're looking much better nowadays.
Thank you, Rita. And I've really enjoyed these little jam sessions. Talking about CRS and how it can fit into the FDN program, and I'm really confident that this is going to make a big difference for people and their practices. So let's see how it all pans out, man, and see how these FDNs enjoy the course.
Yep. Thanks a lot, Sandeep. We'll talk to you later. Bye-bye. Good job.
All right, Matt. Thank you very much. Thank you. Bye.